forum also, that this Physician Forum of India is a unique forum. That I think I have never seen any society or forum like this anywhere in India who has done continuous more than 970 CMEs, as he has told. So our first speaker today is Dr. Debashish Chaudhary. He is Director and Senior Consultant in the Department of Surgical Oncology and Robotic Surgery in Narayana Hospital. And he has done his MPH in Surgical Oncology from Tata Memorial Hospital, Mumbai. And then he was for 7 years in Tata unit of Punjab. And now he is Director in Narayana Hospital. He will speak on the role of surgeons in robotic surgery, but because we know that robotic surgery is not done by actually robots. So surgeon is the key person. So let us hear from him what is the role of surgeon. We all know that surgeon is important, robot just helps him. So let us hear from Debashish. You can start your talk.
Thank you, sir.
अभी रुक जाओ.
Thank you, sir, for the kind introduction, and I thank this forum for giving us this opportunity.
स्पीकर के ऊपर ये वाली बंद कर दो. स्पीकर
Congratulate you as well
उधर वाली.
because of the lot of good news I have been hearing while I was sitting over there. I chose this topic very deliberately. I would like to quote one of the incidents which I noticed in the OPD. What I found was एक patient था, उसको carotid mass था, and it was proven to be malignant. Surgery के लिए plan किया था. We did a PET scan. It was a localized disease, so the next plan should be surgery. I was very astonished. Surgery का तो patient ने बोला कि can this surgery can be done robotically? Then I realized, as a surgeon, maybe some part of the information is not going into the society very well. हम robotic को इतना promote कर रहे हैं कि किस जगह उसका सही use है. That has been actually mistaken. So this is a short introduction about myself. Sir has already told. I did my MCH from Tata Memorial, and it is almost 16 years I have been practicing surgical oncology. I worked as a faculty in Tata Memorial for almost 7 years, and for last 3 years I have been in Delhi, and had a very beautiful journey with Narayana Hospital till date. This is a very strange thing which I encounter. जब भी मैं कभी अपने बारे में introduction देता हूँ कि भाई I am an onco surgeon, sometimes people ask क्या आप करते हैं? वो तो ठीक है, you are a surgical oncologist, but what you do? So these are all the areas where I work, where I have been working for last 16 years. I do head and neck surgeries, I do breast oncology, including oncoplasty, mastectomy, reconstruction. I am trained in doing the GI surgery, including hepatobiliary, and I also do robotic surgeries wherever possible, and I select my patients very carefully so that the actual benefit of robotic surgery is harvested. Again, why I chose this topic was to clear some gas, some clouds around the scope of robotic surgery that we talk about. So these are the areas where robotic surgery has a role. It has a role in urological surgeries like nephrectomy, but I would say a better indication would be a partial nephrectomy, because partial nephrectomy में जब suturing की ज़रूरत होती है, it does a very beautiful job. GI surgery again, hepatobiliary is my first choice because again जहाँ suturing की advantage मिलती है, that is unparalleled. For routine colonic dissections, I personally don't prefer robotic because it's a very straightforward surgery. It doesn't need a robot. Lung surgeries, I mostly prefer robot, and the reason is that when we are working near the mediastinum, it's a very critical area. A lot of blood vessels, major blood vessels are there, and any error because of mishandling or any iatrogenic injury can be catastrophic for the patient. And why I am saying this, I will in my following slides I will tell the advantages of robotic surgery. Head and neck surgeries also, the role is commonly coming up, especially in thyroid, and for early base of tongue, oropharynx also, it has a very good role, especially T1 and T2 lesions. That means only localized, but it should be node negative. What I have realized is a lot of oropharynx and base tongue have been resected robotically, but ultimately they will also require radiation. So in such situations where the need of radiation is already anticipated, robotic has no role. And another advantage, another area where robotic has a role is gynecological surgeries. This is another interesting slide which I wanted to emphasize is, if we have a hammer, everything should not be taken, everything should not be anticipated like a nail. We have to choose very carefully. The patient selection matters because the right outcome with the right technology are best received, best perceived when we choose the right patient. So what are the advantages of the, I am sorry for this slide, actually I had made in the keynote in MacBook, but while transporting to this PPT format, some format was disturbed. My apologies for that. So the advantages of robotic surgeries, I would say, like we are viewing in the real life, it's a 3D vision. So in robotic surgery we get a 3D vision. Number one. The other is the movement of the arms. It's like a endorist, like we are moving in all the 360-degree directions. The same movement can be done in a robotic surgery. Another advantage is some of the surgeons have in-field tremors. So whenever tremor is there, and these kind of surgeries, when they are done with robot, that tremor is gone. While in laparoscopy, the reverse happens. The tremor is maximized, is more amplified. So by this slide, I want to show the critical. This is the slide showing the resection of the lung. You can see the major vessels. How beautifully a resection with a very precision-based technology by robot has been done. Any slightest error in this area would have been very catastrophic. Again, the core principle should be about judgment, selecting the right patient. That is the whole idea of this talk about. So like I mentioned in my introductory slide, in my introduction, that robot has an advantage definitely whenever there is a suturing technique required. So for me, my core area where I work is breast oncology and thoracic oncology. So I see a lot of lung cancer patients, and I do sleeve resections also. Sleeve resections are basically lung parenchyma preserving procedures where we avoid a pneumonectomy, where we avoid multiple lobectomies. So what we do, we remove a part of the bronchus along with the lung and rejoin anastomose with the bronchus with the bronchus. So you can see that it is just, when we use the robotic, it is just a replication of whatever you are doing in the open surgery. Your movement of the wrist will directly be doing the same action in the field. So for me, the advantage wherever there is a scope of endo within the cavity suturing, that area robotic has an unparalleled advantage. Another area is narrow pelvis, especially in the males. Dr. Sumit does a lot of prostate, and he can share his experience. Maybe when we are operating prostate, already the anatomy is very narrow, and in that space, if we have a lot of instruments and a poor vision, the resection and the preservation of the vital nerves which are required to preserve the sexual function, they are compromised if the technology is not right. With robotic, nerve sparing can be done beautifully. Again, because the advantage is that it gives a very good vision in a narrow pelvis, and the movement, the amount of dexterity that can be done with the robotic arms is just unparalleled. Again, robotic surgery has a flip side. A normal cost of surgery, suppose if it is around 3 lakh for a colon, we must add another 1.7 lakh to 2.25 lakhs additional robotic cost. So patients who are not of a very sound financial background, for them offering robotic surgery, patient will do what you suggest. It is your wisdom to tell them that in your case this surgery can be easily done with a laparoscopy. Let's not waste your money in robotic. And again, robotic surgery definitely has a role, but it has a limited role when the disease is locally advanced. In locally advanced diseases, still the gold standard will be open surgery. And again, robotic surgery has a learning curve, and that is actually out of the purview of this discussion. We are anticipating that most of the people who are doing robotic surgery are already well trained. So when I make a decision, I never ask the question that can this surgery be done robotically, because in that case the answer will always be yes. Any surgery that is feasible by laparoscopy or VATS, video assisted thoracoscopy, can be done with robotic. But the question that I ask myself is, will this patient get a benefit from robotic surgery? Because our core area, our core practice is patient-centric and outcome-driven. So meanwhile, while we are having this discussion, there was a study that was published almost 6 months back, and we are now talking a lot about AI. So will AI have a role in surgical procedures as well? So this was a study where I will just mention very briefly. So what they did is they trained the robot with the anatomy of the gallbladder, and they repetitively trained the robot that this is the critical anatomy and this is how the steps are done. So ultimately the robot was trained and he did in a dummy patient cholecystectomy. So the future is maybe the robot will replace the surgeon as well, but still it has a lot of time. So again, the take home message is the right patient, right technology and the right surgeon will give the maximum output that is desirable, and that is what we want for the patient. With this, I will end my talk, and thank you so much.
Thank you, Dr. Debashish, for a very short and crisp, I think, message. So we'll take questions after the second. Thank you. So you gave a good message that ultimately a surgeon is a master, not robot. Surgeon has to take decision when to do robotic surgery, and when you are doing robotic surgery, then also the master is surgeon. Our second speaker is Dr. Sumit Gahlawat. He is director and senior consultant in the Department of Urology, Robotic and Renal Transplant in Dharamsila Narayana Hospital. He has done his ISDT, that is MCH Urology from PGIMER and RML Hospital, Delhi, and he has in special interest in endourology and minimal invasive surgery, renal transplant. He has done more than 125 renal transplant. That's very, and considering his age, I think that's very big achievement. Also, he is interested in uro-oncology and reconstructive urology and robotic surgery procedure. So today he has chosen a very simple topic, which is very, I think, important, because hematuria is not, it's not a disease, it's a symptom, and it can be due to many benign diseases and malignant diseases as well. So let us hear from him what he wants to give message. I think he also will give a short and crisp message as Dr. Debashish. Dr. Sumit, you can start with that.
Thank you, sir. It will be definitely a short and crisp message, and I'll be just dealing in 8 to 10 slides. So hematuria in adults is a separate topic than children, so I'll be just touching it, the hematuria in adults. And it is considered as a red flag, and what's new in it. So we as a doctors are basically aware what is hematuria, what is cross hematuria, what is microscopic hematuria. So just to basically delineate, hematuria can arise from the glomerular cause, that is where the urine is forming, or postclavicular. Anything which is happening at the glomerular level is basically considered as a nephrological cause, and anything after it basically considered as a urological cause. So glomerular cause can be diagnosed on the basis of RBCs, cast present in the urine routine examination. This is a basic simple investigation. Any patient coming with a hematuria symptom, adult patient, should be investigated with urine routine, urine culture and ultrasound. This is very basic investigation, and urine routine will show you significant proteinuria, dysmorphic RBC, red blood cast, or any infection is there, nitrites may be positive or maybe there is bacteria. So by urine routine we can rule out if there is infection or not. If the pustules are not there, if there is nitrite negative, then we can rule out. Even the culture shows bacteria growth, then also we can say that patient is having asymptomatic bacteria, not having UTI. So on this examination we can conclude that glomerular source of hematuria is there, and then we can manage accordingly with the help of a physician or nephrologist. So the multiple or common causes associated with glomerular hematuria is IgA nephropathy, Alport syndrome or basement membrane diseases. Recently we managed a 19-year-old boy with Alport syndrome, and he was on dialysis since last 2 years. Her mother donated her kidney and then he underwent the transplant. The patient is doing well. So basically the management depends on what kind of symptoms are there, what stage of CKD or chronic kidney disease is the patient, and if he is landed up already in the ASRD or he is about to undergo dialysis, we can consider a preemptive transplant also. Nowadays preemptive transplant is gaining some momentum. So there are proven advantages, and there are many studies which show that if the patient undergoes transplant before starting the dialysis, then the results are better in terms of the longevity of the transplant kidney which is given to the patient and the survival of the patient overall. This is because the patient's cardiopulmonary status is preserved when the dialysis is not started. Once the dialysis started, his cardiopulmonary reserve is gone and his ability to tolerate the procedure or the immunosuppressive drugs is hampered. And the second thing is dialysis. The patient who are not started on dialysis, in society it's difficult to counsel them or to tell them that they are needing a dialysis transplant and can be done. The transplant can be done for them, because everybody wants that. Maybe this is a temporary problem or the kidneys are affected temporarily and we can have a Ayurvedic or some other tablets or medication and we can get cured by that. But that's not the scenario in most of the cases if they are having CKD or intrinsic damage of the kidney. The second cause or urological cause of hematuria is upper tract causes. Upper tract, that means kidney or ureter. So kidneys, it can be because of the stone is one of the most common causes. As Delhi is also in one of the state stone belts of the India, the stone cases are very much, or that patients from the Haryana and Rajasthan are also coming, so they are also affected by the stone. So nowadays the latest treatment for that is RIRS for preferably smaller stones less than 2 centimeters. If the stone are bigger, then FANS RIRS, that is continuous aspiration is done along with the suction tube, and the bigger stones can be removed, and we can remove them intraoperatively only. We don't leave any fragments or small particles in the kidney so that they can be drained with the digestion. FANS RIRS is a significant advantage with higher power laser, TFL lasers, 100 watt Holbein lasers. RIRS is gaining momentum and the number of RIRS have increased in comparison to PCNL. First it was open, then PCNL came, now the RIRS is the latest advantage. Second cause of kidney related hematuria is renal cell carcinoma. Most of the times once the patient diagnoses himself having or have symptoms related to the kidney mass, then it is a late situation, because the symptoms are coming late. Once hematuria is there, that means PCS, pelvic cholesterol system, is infiltrated, or the patient is palpating the mass, that also means the mass is very big. So what is the way out is ultrasound scanning maybe yearly. We are getting our blood test done yearly, ultrasound can scan, and small masses 1 centimeter, 2 centimeter, 3 centimeters can be picked up on ultrasound scans. And these scans, once they pick up small masses, then partial nephrectomy can be offered to them. That can be done laparoscopically or robotically. Robotically definitely have advantage in this kind of situation, and partial nephrectomy is better than robotically. So this is the latest advancement, partial nephrectomy. And transitional cell carcinoma, normally we don't advise partial nephrectomy in these kind of cancers because the PCS is involved and the recurrence rate is very high. So in these cases, radical nephrectomy with cuff of the bladder removal is the standard treatment. Urinary tract obstruction can also cause hematuria, and pyelonephritis as a cause of infection can be treated with antibiotics. Coming to the last portion of the tract system, that is lower tract, including bladder, urethra or prostate. So a UTI can most often commonly affect the bladder, that is cystitis. BPH is very common after 50-60 years. Many males have that. And transitional cell carcinoma of the bladder, urinary bladder, and spurious hematuria, that means falsely representing as hematuria as the cause is menses. And benign hematuria, that is the patient is having symptoms because of the infection, that is trigonitis or cystitis, and representing as hematuria. The latest advantage or advancement in the management of bladder tumor is in toto enucleation of the bladder tumor. First, we used to remove it by piecemeal, like QRP we are removing in pieces. Similarly, the bladder tumor is removed in pieces. But the studies have shown that there may be chances of seeding of the bladder tumor in the normal mucosa which is remaining in the bladder. So some small cells can seed there, and there are high chances of recurrence. So the way out is we go to the base of the tumor, use laser and remove it in toto, and enucleation is done, so that it is not broken piecemeal and the chances of seeding and recurrence are decreased. So that's it. Thank you.
Dr. Sumit, please come here. Can we have the lights on? So we had two wonderful sessions, and I know that there are very few surgeons in the group. Dr. Bhalla is one. Dr. S K Poddar sir, I know. I don't think there are some ophthalmic surgeons, Dr. Naveen. There are gynecologists, but I don't think we have general surgeons or onco surgeons in the group. If I'm mistaken, I'm very sorry. I'm sure you would have a lot of questions, and I would set the context for the second talk, Dr. Sumit's talk. Sir, you mentioned about hematuria. We have, this is a very common condition that a physician faces in the clinic. And you mentioned, which, for me was an absolute revelation. If it is a glomerular cause, go to a nephrologist. If it is a tubular cause or an interstitial cause, probably you should go to a urologist. So that was great, honestly. जो चीज मुझे सर 44 साल के एक्सपीरियंस में नहीं मालूम चली, वो आपने 1 सेकंड में बता दी। नमाज का कैरी होम मैसेज है सर मेरे लिए। Glomerular nephrologist, tubular urologist. So great learning for me, sir. Sir, I want to ask you, how do you investigate whether the cause for the hematuria is glomerular or tubular? Your take on that, sir. You can take the mic. Tubular versus glomerular cause of hematuria.
So glomerular versus non-glomerular cause of hematuria.
Yes, you can say that.
Yes. So basically 3 investigations which I advise to my patient: basic urine routine examination, kidney function test, and ultrasound KOB. Urine routine will point out on the basic test which I told, infection related, glomerular blood proteinuria is there, RBC cast are there or not, and ultrasound will tell if any functional of physical abnormality with the urinary tract is there or not. Any mass, any hydronephrosis, any stone, whatever it is, it will point out.
Sir, I still want to ask you, what is the differentiating feature between a glomerular hematuria and a non-glomerular hematuria? What is the gold standard? I would like to ask you.
So proteinuria and RBC cast. These are
RBC cast points to
glomerular.
and proteinuria points to
Glomerular.
glomerular. All right. Very good. Sir, does pain come into the picture? A pain less hematuria versus a painful hematuria. How should we interpret it?
Painless can be because of glomerular causes also, non-glomerular causes also. Like in urology, if I discuss, there is gross painless hematuria, that is diagnostic of this bladder mass in old patients. One of the most common causes. Pain mostly with stones or infection, that is related with the pain.
I saw in one of your slides IgA nephropathy. It also leads to hematuria?
Yes.
Alright, how to diagnose IgA nephropathy? A message for my physician friends.
So once I see that it is a glomerular cause, I refer to my nephrologist. I'm a urologist.
No, but you still need to tell me how to diagnose IgA nephropathy. Kindly tell me.
That's how I do it. I don't go in depth for that.
Alright, you refer to the nephrologist and that's the end of it.
That's the end of it for me.
Right. You also showed a slide on hypernephroma or let's say renal cell carcinoma. What is the commonest presentation of renal cell carcinoma?
Sir, in government setup, I used to see patient having renal masses with hematuria, pain or sometimes palpable mass.
Sir, the
In corporate,
presentation will still remain the same.
no sir, I'll tell you, in corporate or private, the patient comes with the ultrasound with asymptomatic incidentally detected mass on ultrasound. That is the most common. I do more of partial rather than radical.
Alright, once you detect a mass on ultrasound, accidentally or incidentally, what is the next step?
I get a CT done, and if it is heterogeneously enhancing mass, I go for treatment for that, surgical.
No. Do you do a biopsy? There is no need for a biopsy?
No, only two situations. If I suspect it is an abscess with enhancing rim, or if there patient having any other mass anywhere else in the body, then that may be because of the metastasis from there to the kidney. That is a rare scenario. Only these two scenarios.
What is the
Very
commonest-
rarely lymphomas or all also can
What is
present.
the commonest site of metastasis for a renal cell carcinoma? Lungs?
From renal to body
Hypernephroma, yes.
hypernephroma.
Which is the
Soft tissue is lung and bones, spine bones, vertebrae.
Alright. Sir, how do you treat a case of hypernephroma? How do you go about planning your surgery and what are the tests that you rule out a metastasis? Kindly advise.
Basically, I get a basic investigation like ultrasound will localize what is there. After that, confirmation of the diagnosis with CECT whole abdomen after routine blood investigation and KFT should be normal. CECT whole abdomen will tell me local staging. If there are nodes involved or the mass is more than 10 centimeters, I go for PET CT for metastatic staging. If the mass is small, there is no node involved, there is no extra renal involvement or thrombus, I don't go for PET CT. Because for PET CT, the kidney tumors are not a good investigation. PET CT is not a good investigation.
But it rules out metastasis, sir?
It rules out metastasis only in given investigations. More than 10 centimeter mass, IVC thrombus or the hilar nodes are involved. Only these three settings. After doing the staging, I advise according to the stage. If it is metastatic, the treatment is different. If it is localized, the treatment is surgery. Partial or radical depending on the case scenario.
Sir, once you have done a radical surgery, let's say for hypernephroma, what is your monitoring of the patient? Is there any role of chemo or radio apart from surgery?
So no role of chemo or radio. Only TKIs are advised if the nodes are involved or T4 disease is there on biopsy. Otherwise, no role of any other therapy. And at first follow up 3 month pe CECT whole abdomen for looking at the local recurrence. Then after 6 months, then yearly.
Right. Sir, many times we see routinely on ultrasounds, people have polycystic kidney disease. Some of these cysts are complex cysts. How should we monitor these cysts and what are the chances that they might be malignant? Your comment on that. They also are very common causes of hematuria.
Definitely. Simple cysts are one of the most common diagnoses on ultrasound, and most of the cases it is benign. If ultrasound is a very good investigation to categorize the cyst. If ultrasound they say okay, there is some septa inside, or it's a thick wall, or it's a complex cyst, then the next choice of investigation is CECT abdomen to categorize it. 1, 2, 2F, 3 or 4. If it is 3 or 4, we have to operate and remove it because there are high chances of malignancy. Till 2F, we can follow it with ultrasound. That's it. If the ultrasound at base and later on at 6 months is same, we need not to repeat a CT. And 1 and 2 we need not to follow only. 2F need to follow with ultrasound and CT.
Before I come to my moderator, I am sure there will be some questions. Yes, I will come to Dr. Chakravarti sir. All the way from Bali. All the way from Bali. Give a big hand to the great sir.
Thank you so much, sir. Thank you, sir. Dr. Gahlawat, sir. I'm a pediatrician, so my question will be directed to pediatrics problem. Hematuria is a very unusual presentation most of the time. But once in a while they could mimic hematuria. What are the common causes which mimic hematuria in children besides the normal other?
Sir, one of the most common nowadays in winters is चुकंदर जो खा लेते हैं. उससे
Exactly, beetroot.
बच्चों में, adults में, old patients में
They come out next morning, doctor, उसको तो खून आएगा. Very right, doctor. Thank you so much for one.
Other sir, hypercalciuria होता है बच्चों में, one of the most common causes जिसकी वजह से hematuria होता है.
Some drugs also will cause red blood.
Yes, sir. This
Rifampicin and all those things.
Yes, those who are taking ATTs and all.
So we have to be careful about that. Thank you so much, doctor.
Thank you, sir.
Dr. S.
So I would like to ask, do you encounter cases of renal tuberculosis because that presents a painless hematuria?
Yes, sir. Genitourinary tuberculosis. Yes.
So how do you go about it?
So the symptom spectrum of those patients is quite classical. Most of the patients are having lower urinary tract symptoms. Those are irritative. That means frequency, urgency, low capacity bladders. These are the most common symptoms which they have. And later on they can have the ureter or kidney involvement depending on the disease status. So we see the disease spectrum. We investigate with the ultrasound or CT if required. Then if required, very rarely biopsy we do from the dome of the bladder for confirmation of the tissue, or urine routine microscopy, urine gene expert can confirm the diagnosis.
Okay. Dr. Sunil Kapoor sir.
A couple of days ago, I read a report of ivermectin use in cancers. So just tell me if it is relevant. Secondly, BCG, injection BCG for bladder tumors. How much?
Sir, ivermectin is not relevant. There were studies, but it was not found to be useful. And intravesical BCG, it's a old therapy, and we are continuing with it. It is still the gold standard for non-muscle invasive bladder cancer to prevent the recurrence and progression of disease after doing TURBT. The problem with BCG is severe side effects. Roughly 30 to 40% don't tolerate it. They have severe irritative bloods, and we have to stop it or switch on to the second line like mitomycin or gemcitabine. Nowadays, the replacement, the studies show that we can use gemcitabine plus docetaxel in place of BCG. So many hospitals in Delhi NCR are aborting BCG. They are not advising, and many urologists are switching to gemcitabine plus docetaxel.
I would request my masters, Dr. Doshi sir and Dr. Khala sir, to ask their questions to our urologist friend.
Great talks by both of them. So, Dr. Chauhan talked about, did you talk about the IgM nephrometry?
I did.
So, the gold standard remains biopsy to diagnose. And there are a triad of three things. One is the bilateral flank pains, the hematuria, and there's another third one. Anybody? Any guesses? Hematuria, bilateral flank pains, and anybody?
Proteinuria.
No.
बता दो सर.
I'm waiting. So that's why I asked. Anyway, no. We already talked about flank pains, hematuria, and another third triad.
High creatinine stones.
No. Okay, let's proceed further and talk about the CA bladder. See, as you said, probably you need to in stage 0 and 1. Probably you need to remove the tumor and then give intravesical BCG. Anybody? What does BCG stand for? Wow, look at that. Such a learned audience we have. Okay, so what about in stage 4 CA cancer? You use targeted therapies here?
Yes,
Because they are unresectable.
we are doing it, sir. We are giving which are non-resectable
But localized tumor radiotherapy plus targeted therapy have good results. Even in metastatic chemotherapy से ज़्यादा preferred है nowadays. The targeted therapy is showing better results, but they are too costly, sir. Roughly.
Right. So my
50,
last
60
question to Dr. Sumit would be, I believe you are a master in CA prostate. So let's talk a little about that. So mostly they are adenocarcinomas, and they're very slowly growing, and 5-year survival exceeds about 98%. So tell us a little, but if you have a metastatic prostate, the prognosis is really bad, hardly 30% of people survive. So talk us a little about what is the latest in the treatment of CA prostate according to the stages.
Sir, the disease which is localized to the prostate, radiation and surgery are equally efficacious. Patient's preference and patient's follow-up capacity does guide for the treatment. Surgery, the latest advancement is Regis sparing surgery, where we do not go in the Regis space, so the continence and erection function is much better post-operatively. Second thing, if the disease is locally advanced, radiation therapy is preferred over the surgery. And if the disease is metastatic, then nowadays the treatment, gold standard treatment is triple therapy. That is chemotherapy, hormonal therapy plus secondary hormonal therapy like abiraterone and enzalutamide are to be included. All these three combo are to be used together. Earlier it was one by one, but now all three are to be used together so that the maximum benefit is there and overall survival also improves.
Dr. Sumit, any advantages of giving the 5 ARIs? Alpha reductase inhibitors in reducing CA prostate?
No, sir.
So, absolutely no role.
There was a long study for 30-40 years which was done, and they have seen that it reduces the size, but it also increases the chances of picking up or having a high risk or
high grade carcinoma seen if you give these drugs.
Yes, sir.
Okay. What about the biopsy and PSA levels in elderly people more than 75 years? How often you recommend?
I do not recommend it for screening. If the patient comes to me with a symptom, I do diagnose it. Whatever the problem is patient having, I have to diagnose whether it is BPH or CA prostate. Then only I do it. As a part of screening, I don't advise.
So no longer screening is recommended for elderly patients above the age of 75 years. And what about the biopsy?
No, sir. Definitely
not recommended.
Not recommended.
So why would that be? Because it's a slowly growing tumor, and as I said earlier, 5-year survival is more than 90%. Thank you, sir.
Dr. Poddar, sir. Sir, I will not take much time, sir. Don't worry. After so many exhaustive questions, my simple 2.5 questions. Sir, nitrites versus leukocyte esterase, which is more important to confirm whether it's an active infection? We usually find both of them rising in active infection. But if one is rising and if one is not.
So nitrite is more important.
Okay.
Along with that, we need to see the pus cells. If pus cells are not there, culture is positive, it's irrelevant. It's asymptomatic bacteria, need to be treated only in pregnant female, or if the patient is need to be managed endoscopically for any surgery.
And also the count of the colony will also matter. If it is less than...
Sir, if the colonies or the count is also more, but pus cells are not there, then also it is not seen.
Yes, sir. Sir, is there any grading? I am not very sure. I see patients at times which are having polycystic kidneys. So we have grading for bilates and pyrates and all. Is there any polycystic kidney grading on ultrasound? It's not given.
There are some studies on the volume of overall kidney. Volume depicts that the larger the size of the kidney, less is the chance that kidney is functioning normally. Actually what happens, the cyst increases and it presses on the normal parenchyma and decreases the renal function. So larger the volume of the kidney becomes, less is the function of that kidney. So there are some gradings for that, but other than that it's only CKD grading, not the...
It's not a standardized grading.
Not a standardized.
And tolvaptan has been used for
yes, tolvaptan
prevention for the further progression.
Yes.
And I see patients responding reasonably well. My last question is endoscopic removal in toto of the tumor how effective it is and how we are sure that we are
Sir, it is started almost 7 to 8 years back. There are some studies from Beijing and Singapore to prove that it decreases the chances of recurrence in patients, and they theorize that this is because of less seeding in the normal mucosa.
The third triad is the AKI. So hematuria, AKI and bilateral plaque. Dr. Debashish, খুব ভালো কথা বলেছেন।
Wait. So I think we any other questions from?
Let me ask you one question.
Wait.
अभी भी जीते हैं यार।
Any other question from our urologist friend? Because we have started from urologist. So any other question from our urologist friend?
No, thank you. No.
So only one message from my side is, though he has said that painless hematuria can be due to glomerular cause, but I think my opinion is you must rule out tumors, whether it is from kidney or bladder or prostate, in the case of painless hematuria before thinking of glomerular cause. So you must rule out bladder tumor. What is your opinion?
I agree. There are urological causes which can also cause painless hematuria.
In the case of painless hematuria, before thinking of glomerular cause, you must rule out tumors. By simple ultrasound can rule out in most of the cases. Yes.
And tuberculosis, sir.
Local spotting and minimal imaging
Vijay,
in the initial stage.
Okay. So I think now we can take questions for I think our.
Sir, I think you had a question to.
Yes.
Now we can start.
Please. Go ahead.
So Debashish, robotic surgery not for everybody.
Sir, एक मिनट बंगाली में क्या बोला था सर?
अभी तो
আমি তোমাকে ভালোবাসি। नहीं, दोबारा बोलो।
খুব ভালো কথা করেছেন।
मतलब
बहुत बढ़िया बोला।
बहुत अच्छा बोला।
भालो।
Go ahead.
So Dr. Debashish, robotics not for everybody. I am laying stress here in patients who have coronary artery disease or who have bronchial asthma or COPD. Would you like to proceed with a robot or would you like to do a laparoscopic surgery?
Because I thought robotic surgery itself is a very vast topic. I just covered very relevant areas.
I understand.
जब robotic surgery हम डॉक करते हैं, इसका एक टाइम लगता है. It takes time. Robotic surgery takes time to initiate. Robot पहले डॉक होता है, उसके arms डाले. So that time is around 1 hour. Whereas laparoscopic surgery or VATS is the counterpart in the thorax. That they are very rapid. जैसे patient induced हुआ, position हुआ, we can. So whenever we see that the patient is at risk, but the patient should harness the advantages of a minimal invasive surgeries, we always, in my book, I always prefer a laparoscopic or a VATS.
Very well said, sir. Why I asked this question was, I recently lost one patient in a very reputed hospital, a very reputed GI surgeon. I would like to take the name. This patient was 74 years old, had coronary artery disease, and had CO esophagus. So it took 12 hours for robotic surgery and we lost the patient. Thank you, sir.
Sir, Dr. Akash Keshri is an obesity specialist. He has a clinic in Lajpat Nagar. We welcome him to the forum. He has already been admitted to the forum. He has promised us to give us CAP in May.
Thank you, sir. Debashish, you had one very interesting slide on where you had presented that the AI was trained repeatedly and then performed the surgery without supervision. So in light of this, I'm very interested to know that in the near future, as things are progressing so rapidly with AI, do you see that maybe the AI will, or how do you see the role of AI in robotic surgery going forward?
This is one of the studies that was done in Harvard. There are multiple such studies that are already being done in China as well. We don't know the result as such, but the same philosophy that you train a robot, because robot is actually what you AI is like you repeatedly make them do the same thing, and they will make on their database, they will make a decision that yes, now I have to do this. So definitely they will over a period of time will be able to do very simple procedures like a cholecystectomy, but whenever the situation where AI is performing in an autonomous mode, a surgery, a surgeon is always required as a standby.
Sir, I agree that the surgeon should be on standby, but in your personal opinion, do you feel that this is an ethical practice? And it raises some interesting questions about who is responsible.
I think if you had if you follow the X, Elon Musk has recently mentioned that in 10 years he will make robots. 10 years or 5 years maybe. He will make robots that will do surgery on their own, and they will be better than the surgeons that are existing currently.
So I do not believe that they will be better than you, and thank you so much.
Dr. Gurmeet Bansal, ma'am, can you please come forward little bit? Ma'am, kindly ask your question. Dr. Gurmeet Bansal is an eminent gynecologist, a friend of my batchmate, Dr. Bansal. Ma'am, please ask your question.
Sir, I have a question for Dr. Sumit. About 3 years has an RCC in one kidney, and the other kidney is affected by medical renal disease and is shrunken. What are the chances of success of a partial nephrectomy, sir?
Surgically it is same. If patient is having 2 kidney or 1 kidney, it doesn't matter. Surgically we do the same procedure, but the motive is to cure the disease, to remove the disease, even if we have to remove whole of the kidney and the patient comes on dialysis, because the disease is so progressive and so fast in such a patient that it get metastasis 6 months to 1 year. The patient has
When we take a patient for partial nephrectomy, we have to take a consent for a total nephrectomy.
always.
What are the chances of converting into total nephrectomy?
Now it depends on the complexity score of that tumor. Yeah, how much is closer to the hilum, and how much big is the tumor, and what is the endophytic status, what is the exophytic status, all these factors. Always we do take this consent that the radical nephrectomy can be done if there is bleeding or if there is the mass is going inside, we are not able to remove completely. In these two scenarios, we may have to convert to radical, because the priority is to save the patient. Second priority is to save the organ. So first priority wins if we have to remove the organ.
Thank you, Dr. Gurmeet ma'am, for this question. Friends, I think we had a wonderful CME. And we had 2 wonderful speakers bringing out their skills and their knowledge. And I'm sure there is a carry-home message. And there is no better person to give us a carry-home message for both the talks than Dr. S K Poddar, our President-elect, Delhi Medical Association. Over to you, great man. Your message for our
I think he has already given a message, Dr. Debashish, that robotic surgery, though it can be used in many places, but the surgeon should decide whether it is beneficial for the patient or not. So it should be an ethical decision that whether the patient will really be benefited by robotic surgery or not. So this should be left to the surgeon. So I think it should not be given choice to the patient. Many surgeons are doing simple gallbladder also by robotic. I think that may not be any of benefit to the patient. And this is regarding Dr. Debashish talk and Dr. Sumit. I think you did very good. You gave very good message that hematuria can be due to right from kidney, ureter, bladder, prostate due to any organ.
Also glomerular, sir.
It's part of kidney. Glomerular is part of kidney. So kidney, ureter, urinary bladder and prostate, all 4 organs can cause hematuria, and also right from infection to stone disease, benign tumor. tumors, malignant tumors. So all these can cause hematuria, whether painful or painless, that has to be seen. So thank you very much, both the speakers. Thank you.
I think after